I'm very, very happy to be here. As you can see that now I have the glasses provided by Septodont as well, they're red. And so I'm here because, as you probably know, I've done a lot of research on pulp biology, pulpotomy, pulp capping, and I am fascinated by the hydraulic cement, sorry, not the bioceramics. And but I'm still an endodontist, and I'm still filling root canal. And nearly 10 years ago now, we launched the BioRoot RCS with a randomized clinical trial that we tried to do in Paris University and the group de la Pitié-Salpêtrière. And for many reasons, we were not able to publish the results. And then 10 years later, nearly, Septodont came back to me and they said, okay, we know that you are not a university, but would you agree to be the principal investigator for doing a randomized clinical trial on the BioRoot Flow? And that's the results I'm going to present today. So first of all, I have no conflict of interest, meaning that I don't get any money from the product sale. Unfortunately, I've tried, but it didn't work. And the only relationship I have with Septodont with this is that I am the principal investigator, and hopefully I was paid for that. So it worked at least for this part. So the first point is, you probably know the S3 guidelines from the European Society of Odontology. If you haven't read the paper, I understand you 100%, because to read the full paper, it's impossible. But you have to read it part to part. And what is interesting is that when you look about the obturation and the recommendation, evidence-based recommendation, you can see the calcium silicate on the paper. And it's very important. Why? Because when you see these guidelines, at the end, you don't do anything else in your practice. You don't use ultrasonic tips to activate the solution. You don't do the access cavity is just a hole and whatever. Why? Because that's the only thing that is evidence-based. And what is interesting that the hydraulic cements came on the market less than 10, 15 years, and they are already accredited by the ESC. So the society did a wonderful work. It's very, very impressive what they were able to do, even if we are frustrated with the final paper, but that's the way of the research we have in endodontics. So bioceramics, calcium silicate are here, good, and then we can go and then now investigate it, what we can have with this. The game changer in endodontics is important because there is an evolution definitely moving to a minimal invasive. We have to remove less and less dentin. And when you look about the endodontics in the past, why did we remove a lot of dentin? Because we didn't have any other technique than compacting warm compaction with the warm compaction technique, the gutta percha. And for that, we need a taper preparation with a very large canal. Using the bioceramics, the hydraulic cement, sorry, I will try not to say bioceramics, but I can't. And using these products that you can inject inside the root canal, you don't need so much space. And what is fascinating is that when you know this guy, I was born in endodontics with him in 1996, Steve Buchanan. I remember the GT file, taper 12%. And now he's advertising for a taper 3%. So something is moving. No, but that's true. I don't say that is moving is code. It's just that's the fact that now we can disinfect the root canal without having large taper, and we can fill them without having large taper as well. So this, I don't know if you have heard about the SAF, self-adjusting file. I'm fascinated with this. And the product has come back on the market, so in Germany and in France only, sorry for the others. And I'm fascinated with this because that's the technique who makes the most sense for me in endodontics. That's the best way to remove the smear layer. That's the best way for me to get liquid water coming from the dentin for having this material to set. So less taper, less space. Disinfection techniques must be revisited, and filling techniques can be revisited. That must be, because by the way, yes, we have to revisit them, because if you get a 3 or 4% taper preparation. It's very, very complicated, not to say impossible, to use a warm compaction of a Gouda perca. So the concept, bioceramic is I like your slides because I'm looking for the word for why. We do not obturate, we fill them. That's definitely the way. And then to fill something, we have to be able to pour in it, and it has to be liquid or close to be. And then, so the Gouda perca is just a way to push the material in the depths of the canal, and then the single cone is it's not the single. We do not seal the cone. We fill the root canal with a bioceramic, and we use the Gouda perca. But on the paper, we could avoid it, but we know endodontists and Gouda perca. It's a long story of love. So the question is, okay, everybody, we have opinion. I love the discussion you had there. Opinion, and it's funny because in OPL, opinion leader, you have opinion. So most of our job is done based on opinion. Research is quite poor. I've done a lot of research, so I am a part of it, but the level of the research in endodontics, in dentistry in general, especially maybe in perio, but the level of research is too poor to produce true evidence-based conclusions. So we have opinion, but is this technique reliable and predictable? Do we have clinical evidence of effectiveness? Does the products influence the outcome? Except if we remove the aliens, so having aluminate inside the root inside the product, is it a problem clinically on the clinical results? I don't know. And does the carrier influence the outcome? Is it science or marketing? And finally, I have to admit, I've been in research again for 20 years. I have to admit that the marketing is launching the products, the science is coming later. Except it sometimes, I agree that the Septodont is one of these kind of company where they think before to launch, and sometimes they launch a little bit too late, but that's another story. So where is the state of the clinical science? So I'm sorry, one line is missing, the Elisabetta papers. Very interesting, because I think that the answer is there. So if someone in the room can do, please, a randomized clinical trial comparing warm compaction versus hydraulic cement, with 2 branch of 160 patients, if you're available to do that, definitely you will answer the question everybody asks themselves. Because when you go and the clinical trial website, there is nothing, to be honest, which will be able to answer the question we have to ask today. So the limit of the BioRoots, okay, it was sticky. For me, too complicated to manipulate. You as the people, I like also the points say teachable, feasible, and repeatable. And unfortunately, when you ask someone, a dentist, to drop 5 drops of a liquid and 1 spoon of powder, at the end, nobody is able to have the same 5 drops. So it's teachable, maybe feasible, but it's not repeatable. And just for that, for me, that was a problem. So having now a product, which is not for me a pre-mixed product, but a ready-to-be-used, because there is nothing to mix, ready-to-be-used products will avoid this kind of problem we had with the 5-drop story. So BioRoot Flow, I had a chance to get this syringe in 2020, just before the problem with the BioRoot RCS, which was removed from the market for EC, blah, blah, blah. So the experimentation, the randomized clinical should have started before, but we had to wait a little bit. And so, sorry, Josette, it's a very nice paper, but I don't have the time. And so this paper, the object of this paper was to provide some results for having for Septodont having the certification, the European certification as a class 3. That's very, very important, because you were talking about extrusion of material, is it resorbable or not? At the end, that's the only product, if you inject it into the bone, you will never be in conflict with anyone, because on the paper, it's an implantable. And it took me a lot of time to understand that, until I had the discussion with Matthias and say, that's the only product I use, because that's the only products I will never go to the court with. So The design of the study was to collect data, clinical performance, and safety on the use of BioRoot Flow. And it was a prospective, quite important, multicentric, 8 centers, 13 investigators, randomized 2 arms, and it was a non-inferiority experimentation. Why? Because Septodont decided to use the BioRoot RCS data and as a basis, and then to see if the BioRoot Flow at least was equal or better, but not inferior to the BioRoot RCS. Open label and pre-market clinical trial because they were expecting these results, and that's what we had a lot of pressure to get a certification. So 7 sites summary, 13 investigators, international because we were French and Belgium, so it was an international one. And what was interesting is that there were 3 endodontists and 4 general practitioners. And for me, that's a very, very important question because everything works in endodontist hands. Having general practitioners, yeah, Elizabeth, yeah, I have to say that because I have to be very polite. Now, anyway, endodontists for trained people, everything can work if you work properly. But in GPs, again, what you teach, sometimes the message you teach is not the message that the people receive because they just want to get it easier, going faster, etc., etc. So having 4 GPs and 3 endodontists was interesting because at the end, we will be able to compare, do we have better results with endodontists compared to GPs? And the results were very important, but they are not published so far. So a long story because initially Septodont came to us and they said, okay, it's only 2 years. We have the only 2 years recall. And now they come back and say, oh, we will go to 5 years. And I swear I will never go further because calling people after 5 years, it's just a nightmare in the practice. On the 7 centers, only 1 the university and 6 private surgery. So how did it work? Time of treatment, visit 1, coronal restoration, and the visit 2. It has to be done in the 2 weeks, 2 or 4 weeks, I don't remember, sorry. First visit at 6 months with an X-ray and examination. Visit 4, 12 months. Visit 5, 2 years. Visit 6, 3.5 years. And I just completed my 3.5 years recall last week. And now we are expecting the 5 years. What is important, that visit 6 and 7 are only for the patient who received the BioRoot Flow, not the BioRoot RCS. So for the inclusion criteria, you got everything. It's always the same. There is a follow-up. The number of patients to include was based on a result of 90% of success. So it makes 60 patients in each group, and we added with 20% more just in case of patients decline or disease or whatever. And that's why we started with 164 patients. I don't know if you have already done some clinical research, but in endodontics, when you have 164 patients to recall in 2 years, your first night are not very, very good. Anyway, so randomization, 160, 2 arms, and then we had the sex repartition, of course, so we did well. Type of treatment, initial root canal treatment and retreatment. Teeth with apical lesion or no apical lesion, no problem to include them, but we were able to track them. And the tooth time, so a lot of molars and premolars, very slow number of incisors and canines. So X-ray observation, they were not the clinicians, there were 2 other dentists who were calibrated with the kappa Cohen at 0.79, 2 readers, 2 readings. So there were 2 readers on their side. After that, we compiled the results. When on the difference, we had a new discussion. So they went back for a second reading, and they came back. And at the end, if we still had some differences, so we had a meeting together, and then we decided for the final score. Big important decision, because we submitted the paper and then the editor-in-chief is in the room, so please read it, listen to what I'm going to say before you decline. Where are you? Where are you? He's not here, good. Anyway, lose criteria, success criteria. So what is the success criteria? What is the lose criteria? That's a big story, so, we always have the same problem. So what we decided, three criteria, listen carefully, three criteria are healing lesion or healed lesion. Loose criteria are the same, plus the lesion who do not evaluate in the bad side. So it means that a lesion which was not decreasing in size but was not increasing was considered as a loose success. It was a success in the loose criteria. We can discuss that. But at the end, you will see the results. The difference between strict criteria and loose criteria was not so big difference. So at the end, you will see that Septodont in the marketing, they only use strict criteria results, just to avoid any discussion at the end. So 24 months recall, I don't remember. So the pain after treatment, you know, it was it is very close to what we have usually in the literature. No difference. Success rate, initial treatment, 91%. What is important here? 91% are endodontists plus GPs. I didn't have the time to select all the data and then to compare, to show you the comparison between GPs and endodontists. The only thing I can say, unfortunately for the endodontists, there is no difference. I'm sorry of that. And you see that between the loose and strict criteria, it's 89 or 91. It's nothing. So we can consider that it's nearly 90% of success with a very easy, feasible, teachable, and then repeatable technique. That's for me, that's a big step. These three words are very, very clever. If you want to get good results, you have to teach them, and then the people must be able to repeat it. So for the retreatment, there is a big difference between the loose criteria and strict criteria, but 82.5%. It can be considered as quite low, or no, I don't know. But when you compare to the published papers on this subject, there is no difference. But, I would say that 99% of the paper published on this topic in JOE and AEG and whatever usually are done in endodontic department, in the postgraduate program. Here, we involved everyone. So what does it mean? It means that the risk related to the experimentation of the practitioner seems not to modify the results at the end. With an apical lesion, or what is interesting, look, about the teeth with apical lesion, we had a better results than teeth without apical lesion. No, sorry, you don't say, no. So what the discussion is, average rates of success at 24 months can be considered 91%. I would say 89, to be honest, because if we get the loose criteria. Based on these results, I would say that both of the products could be considered as safe for root canal filling. 3 more years follow-up are forthcoming, actually, so the end of the study will be 2026. And then we can consider, for me, if we go over the question of the material, considering the technique as a single cone with a filling material can be considered as a relevant technique. And it's very important because warm compaction is just a pain to teach, it's a pain to repeat, and it's to complete. And at the end, it's repeatable, but only for very well-trained dentists. So the discussion is, on my knowledge at least, it's the only randomized clinical trial completed on the evaluation of efficiency, so not bioceramic, hydraulic cement, and the single cone filling technique. I remember in 2014 or 15, I don't know, Jérôme or Gilles can say that, when we launched the BioRoots in Paris, and then I did a conference, I gave a conference to the teachers of France in endodontics. It was in Nice. And I just showed that, okay, we can fill can fill the root canal with in a different way with these products. And I remember it was a big nightmare in the room. Everybody wanted to kill me. And they say, okay, you can't say that. So it's only warm compaction, blah, 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 blah. I say, okay, I don't say that warm compaction is a bad technique. I just say that maybe, for at least for our students, there is a window somewhere we could help them to like, not to love, endo. You know, so the endo is the enemy of a student, and trust me, I understand them. Okay, so actually, 15 years later, the story smells differently. And again, I don't say that we have to remove and the warm compaction is dead. Not at all. Not at all. But there is something who can be more investigated. Sorry for the bioceramic story. So we must keep in mind that filling is efficient as long as all the other part of the treatment has been completely done in the right way. Okay? So the endodontic is not only a problem of filling, of course. It's a question of shaping or disinfection and filling. So I'm still using the warm compaction in some cases, and because I like it. And when you like compacting gutta-perca, you continue to do that. And I think that if I had not a continuous, I remember you said that you use the HEDP. For me, that's the combo. Because Josette say that not having a good chelation mean that you won't be able to remove the liquid from the dentin, and then you need a very nice preparation of the root canal surfaces. And so I'm using the HEDP now for 4 years, and for me, there is a key somewhere. EDTA